Folks, it's a special episode of Healthcare Unfiltered. I am always humbled and honored when I have someone who really is a patient advocate who puts patients at the center of their career journey. And I am very happy and delighted to have with me Dr. Grace Cordovano on Healthcare Unfiltered. It's the first time that Dr. Cordovano comes on Healthcare Unfiltered, but judging from her amazing work, it's not going to be the last time. Grace, welcome to Healthcare Unfiltered. I appreciate you taking time this morning to chat with me.
Thank you so much for having me. It's great to reconnect after ASCO.
Yeah. So I want to start by the boilerplate of who you are, because I think when I just give a little bit more of a platform and a level set with listeners and viewers as who you are and how did you evolve into becoming a patient advocate.
Thank you for that question. So, I'm a board certified patient advocate and I specialize in the oncology space. My day to day is helping patients and their families from point of diagnosis through survivorship or end of life care planning. My goal is to help reduce suffering, to help connect people to the information, tools, and technology they need to make an informed, educated decision about their care. I'm working with patients and families, boots on the ground, attending appointments, and after the appointments, I'm on the phone at 2 o'clock in the morning when people can't sleep, trying to help them understand and navigate their diagnosis. But more importantly, and the most difficult part, is trying to navigate the US healthcare system and its fragmentation and barriers that are often in the way of getting the care that they need.
Tell me about board certified patient advocate. I admit I did not know there's a board certification for that. Tell us a little bit about that. What does that mean?
Sure. So it's an internationally recognized credential. It's offered by the Patient Advocate Certification Board. It's a test that's offered in the spring and the fall, and it can be repeated every 3 years, or you can opt to do CEUs and continuing education. And it's really geared to help patient advocates be savvy and practice at the top of patient advocacy with a credential. So it differentiates someone who may be simply working and volunteering their time versus someone who, like me, has their own practice and really works deeply in individual patient cases, taking a deep dive into their medical records, understanding all of the nuances of their life with a diagnosis, and I work under a retainer model and also help work with pro bono cases, but it's really more of a business model so that it can be sustainable. And it is something that is really necessary because when patients are looking for support, they are trying to understand who is really carrying the most expertise and knowledgeable. Many people identify as being an advocate after helping a friend or maybe a loved one, but there's a depth of knowledge and expertise when you're a board certified patient advocate and understanding how the US healthcare system, hospital systems, medical care work.
So what made you do that? I mean, is there a story behind the story? What made you decide this is the career path I would like to do?
So I've been navigating US healthcare since I was a kid. English is my second language. My family immigrated here from Poland, and I didn't speak English as a child when I started school. Once I got the hang of speaking English, I became the
I
go-to
had to
person.
say I thought it's Italian based on the last
It's
name.
Polish. I'm married into Italian.
Oh, I see. Okay, I got
Yes,
one.
so you were close. But there was never a translator, so I was using an encyclopedia and dictionary to help family, friends, parishioners, neighbors understand what was in the handwritten notes, what was on the prescription bottles. And I eventually had to navigate numerous cancer diagnoses, but really what the turning point was my own cancer diagnosis. I was diagnosed with advanced lymphoma. I took my medical records and got a second opinion at Sloan. After 4 months of tests, biopsies, imaging, surgery, I had video assisted thoracic surgery. I got placed in isolation after surgery for potential tuberculosis. It was determined I did not have a cancer diagnosis, that it was a fungal infection I had acquired on my honeymoon called histoplasmosis, which only required monitoring because a healthy immune system will clear it. I realized at that point I had a PhD, I had access to insurance, I was receiving care at a center of excellence that people come from all over the world, spoke English. And the process of it still brought me to my knees. And had I not gotten my medical records and gotten a second opinion, my life would have been very different, as I would have been treated aggressively for advanced lymphoma. And all I could think of is as the all the stars really aligned. I had read an article in the newspaper about patient advocacy as a profession, and I was surprised that you could do that professionally. Took some business, took some finance because they don't teach you that in grad school, and opened up my own practice, which is Enlightening Results. And that's how I work with patients now for many years now, in the form of being hired or representing someone from a pro bono standpoint.
This is really an amazing story that, you were, I mean, you almost were be getting chemotherapy for something that you did not need chemotherapy for. So I can totally appreciate the confusion that you went through. And I'm glad that things were resolved. And I think you hit the nail on the head by saying that there are many people who are probably not as educated as you are, and probably wouldn't have had the resources to go and get that additional opinion,
Yeah, that definitely had a big role in my life and a profound impact. And it also left me questioning, why me? Walking
Right.
out of a cancer center, not having cancer is a miracle that I think so many people pray for. And I've struggled with that for a long time. So I find a lot of joy in the work that I do in serving the families and patients that do come my way, and hoping that I can somehow relieve some of the suffering that they're experiencing.
The your PhD is in that, or is some different field?
Biochemistry of metabolic disease.
Biochemistry. So how, like how would I, like, who calls you to seek help? Is it a family of a patient? Is it a patient? Is it a doctor say, hey, I have this family, I probably can use your help? Social worker? Like who 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 emails you, texts you, or call you?
Usually it's the patient's care partner. It's someone who has been watching their loved one struggle. Either they're newly diagnosed and they can't connect to the right care, they're struggling to get a diagnosis and they can't perhaps get a second opinion or get a tumor board organized. There's someone who is experiencing a treatment that has failed them and disease progression. There's someone who maybe has a rare disease, or there's someone that's really something catastrophic where there's just multiple things going on. The people who contact me are desperate and they are willing to make a deal with the devil because they feel that all options have been exhausted. So I think that the majority of people, it's not just a simple cancer diagnosis. I look at it through the lens of extreme suffering and extreme earth-shattering conditions where people want to get care. They just cannot connect to the right person, or the right person who will listen and take the time to review what's often an extensive amount of medical records.
Why is that? How did we get here? Like, why did we get to a point where, in every industry, like, I feel like we're a little bit more organized, I guess. I mean, I realize healthcare is just very different, but I mean, to your point, it's a very confusing world out there for people who are entering that world for the first time.
Mm-hmm.
And let's face it, not everybody is going to be able to get your services.
Mm-hmm.
So yes, you're helping some, but for the, like, how can we evolve to have everybody helped?
Mm-hmm. I think we need to standardize a few things, at least on the patient side. I think we would run out of time talking about all the things that are wrong. I don't want to wallow in what's wrong. I want to point out things that would definitely make a difference because I see it in my daily work for over 20 years. Patients don't, and their families don't have access to tools and technology they need to really present themselves in the best business light. We're faced with clipboards and photocopies, scanners, and we're given poorly photocopied intake forms. And then we don't have the time that we need to be organized and present our case. At best, you have 7 to 15 minutes, maybe with a new oncologist, maybe more. We don't have access to all of the medical records. We can't collect all of our images. When we get our images, they're on CD. We don't have access to pathology. We don't even have an image or a DICOM of what our pathology looks like. We don't have sophisticated educational materials. We're not connected to peer health support communities very directly. We treat each patient as though they're the first one on the planet to walk with a diagnosis, and rattle off some information and send them on their way instead of immediately wrapping the patient around everything that's readily available. And this is not a technology problem, because we have so many wonderful tools and technologies and digital health tools out there. They're either not reimbursed or they're just not celebrated and connected to the right people at the right time. Having all of the medical records and simply creating a timeline and a one-page summary, which maybe Chat GPT could help write, or the Docs GPT could help write, would better position any patients to a oncologist or care team that may be strained with resources, to be able to quickly see what has already been done, what time, where was it done, what were the outcomes, give me a summary of what's going on. Is this a fit for me? Is this a better fit for a colleague? Should this go to tumor board? Should this be sent to another hospital or a cancer center somewhere across the US or internationally? So right out of the gate, we're failing in that very simple piece. And then it continues. Clinical trials are introduced way too late. And by then, many patients have either gone through too many different treatments, or they don't meet the exclusion criteria. The list goes on and on and on. We don't give patients tools to monitor treatment-related side effects. So by the time they see me that they're so sick, they don't even know if is this the cancer that's causing the side effects. They don't even realize that it's often treatment and dehydration and lack of anti-nausea medication that could make all the difference. I'm asked so frequently, and actually have been laughed at, well, we can't scale your work. Same question that you posed me. Not everyone can afford or access your work. And I'm very mindful of that, which is why I partner on the national level with many organizations to try to pull more patient voices in, as companies and health systems and payers and various organizations build out the future. That the patient and care partner and family has to be a stakeholder that's part of the co-creation process, whether it's from policies, whether it's from innovation, whether it's from budgeting. If that voice is missing, we're going to continue to fail.
Yeah. And you've been doing this for a long time, Grace. So we'll go over some of the changes that you have observed over the years, because I presume some of the challenges that existed 20 years ago are not the same as today. They may be better, they may be worse, but certainly they're different type of
Absolutely.
challenges. So I want to try to, to illustrate to listeners and viewers maybe a few cases and have you educate us as to how you navigate some of the issues that patients face. So you mentioned a lot, second opinions and tumor boards. In my view, for example, cases put in on tumor boards by the physician and the healthcare team that is taking care of patients. So what do you do? Like, you have a patient that calls you and you realize that maybe this case should be discussed in a multidisciplinary tumor board. Some of them may have already been discussed and the patient is unaware. Some of them are not discussed because maybe the healthcare team thinks it's straightforward, it does not need discussion. What do you do? You pick up the phone and call the oncologist and say, hey, my name is Grace, I represent Mrs. So-and-so. And like, how does this actually work?
So many great questions. So I want to address, first of all, the second opinion piece. So many patients are afraid to seek a second opinion. Some may not be able to access that second opinion. A second and sometimes third opinion are absolutely necessary until we're confident that that diagnosis is correct, and we're confident that the treatment plan that has been laid out is something that the patient is capable of affording, doing, and managing, given their life circumstances. When I see a gap there with an uncertainty on the diagnosis and an uncertainty on the treatment, we need to go and engage into a second opinion. How do we get a second opinion? I gather the medical records and understand sort of where the patient is with what records have been generated thus far. It can be from looking into Cancer Center of Excellence, and just really at this point in my career, I know who the key players are in which disease states, and also from what research they're presenting. Some patients really do need to start looking more towards tumor markers and tumor agnostic situations and in guiding their care, instead of just this is breast cancer, or this is prostate cancer, or this is melanoma. So it's a matter of exploring how much innovation has been included in a patient's care at this juncture. I see a lot of patients that have no sequencing, that have no tumor markers. There's very little pathology done. And that's very concerning, because we do see the difference in care in connecting to something more targeted. So I'm very disappointed by how we're lacking with the precision medicine approach of understanding how to treat a tumor. And it's very concerning. I'm in northern New Jersey and in the Manhattan area, and there's some people that are doing a fantastic job, but I see a lot of cases where patients are not connected to what's routinely available and should be routinely available. The tumor board situation, well, here's what's frustrating. Something that's very frustrating to me is if a tumor board's been done, there's no notes from it. It's not documented in the EHR. I have no way of knowing what's been discussed. Usually what is done is it's a simple phone call that's relayed and saying, well, we met and here's what we've decided. Thanks. But there's no opportunity for follow-up questions. We have no idea who was in the room. So there's really sort of a lack of transparency. And there's also not a willingness to have a patient attend that tumor board, because we don't know if you have all of the records, if you have all of the information. So there's a lot of friction points from a logic and workflow and strategy standpoint, where I have been included in tumor board discussions, and they have been a beautiful collaboration. And I'm frustrated that that's not something that's extended to all patients. And I do realize the time crunch. I know that it's logistically not feasible to include every patient in every tumor board, but it's not even an option for anyone really. So those are some high level friction points that I think we could address, or I'd love to see addressed asynchronously, at least with some digital tools.
Do you feel that you help patients interpreting the results? And is it, I'm trying to understand how much of this, Grace, is the physicians and the nurses are not doing their jobs, frankly, or they're doing the best that they can, but with the limited time, they just can't spend an hour keep going over the same thing. So, they explain things and move on. So the patient is left still with so many questions and very little time to answer. And that's where you come in and help.
Mhm.
I'm trying to put my fingers on the pulse of where the breakdown is, because you get a CAT scan result. I think every physician will sit down and tell the patient what the scan shows. But I can imagine a scenario where, despite all of this explanation, it's still not registering. And then you come in and spend ample time going over every detail and clarify things. Am I on the right track there? Is that what happens?
Absolutely. I really see myself as an extension here of the care team in filling in the gaps, even in situations where my colleagues in medicine are doing a phenomenal job. They're spending an hour sitting with the patient. They're sending the patient home with a diagram that they've hand drawn. They're going out, they're turning their screen and going over everything, and we all have an understanding. But that doesn't mean that an understanding at point of care in the exam room isn't going to then translate. I actually think the better job a care team does in explaining, the more questions come up, because now you have a working knowledge of what's going on. And I also want to point out, we're only talking about a cancer diagnosis. Patients often have many other different diagnoses and comorbidities. So, what does the intersection of all of those together, and the medications and the procedures and the care that's required to manage the other conditions, how does that work with cancer? How does that work with a working mom that may be pregnant and doesn't have childcare and access to transportation? Things get very complicated, not necessarily because the doctor and nurse aren't doing their job. It's because life is complicated once you walk out that door, and it's all of the different parameters that need to fit together to make treatment work and make care successful. one of the biggest challenges I'm facing now, I'd say in the last 6 to 9 months, is a growing number of insurance denials. Standards of care are being denied, prescriptions are being denied. It seems like 60 to 70% of the care that is being prescribed to the patients I work with require some type of authorization, a letter of medical necessity, an insurance appeal, an hour-long phone call, a peer-to-peer with the oncologist. And when you look at what's being published, you're seeing reports of payers using AI-powered decision support tools that are batch denying these types of care. And I think that the statistic was, or the estimate was, that 1.2 seconds are being spent on reviewing, quote unquote, a claim, and they're being denied. So I think, if also I'm correct, I think less than 2% of all insurance denials are appealed, which means patients are either foregoing care or they're paying for it out of pocket. So this is just unsustainable. So there's a lot of different factors. To your point about are people not doing their job, I think there's additional things stacked up against them where there's many patients, so much administrative burden. I think the biggest problem we have is the administrative burden from a physician side and from a patient side. The patient administrative burden, or the work that people need to do to get the care they need, is just unsustainable. It's not possible to do. It's a full-time job, and people are really sick and they're tired, and many give up.
Yeah. I want to talk about pre-authorization a little bit because it is, come on, it's pain in the ass. It's healthcare unfiltered. I could say whatever I want. That's
Yeah.
why it's unfiltered. But this has been a constant issue.
Mhm.
And you hit the nail on the head again, that the way payers make money is by reducing cost of care and sometimes, unfortunately, denying care, some of which is appropriate. Let's face it, there's over-treatment, but a lot of it is not appropriate. So what do we do? I am sick and tired of hearing about it because we all know it's a problem. I was, back in the day, I was told clinical pathways are going to get rid of pre-authorization. Well, it didn't.
It didn't.
So, what are there solutions to this?
I can tell you what I'm doing to help patients, but it's not enough. I'm using, tools like ChatGPT or DocsGPT to help write the letter of appeal and demonstrate medical necessity. I'm helping make sure that patients also have the medical records accompanying that letter. 9 times out of 10, when you call the insurance company, they don't have all of the records documenting medical necessity. So it's an understanding of, for that diagnosis, what does your payer, quote unquote, need as evidence for medical necessity. Sometimes the wrong specialty is reviewing. You'll have like cardiology reviewing the need for chemotherapy, so taking down the name number. I ask for the license of the practicing, quote unquote, physician that is doing the denial. And it's pushing and it's teaching people to push against and not accept no for an answer. I think at a higher level, we really need tools for patients to be able to automate this process. I think it's largely fallen on our doctors, and the doctors can't keep up. So again, when I speak to my colleagues in medicine who are doing these peer-to-peers, they're sitting on the phone for 45 minutes to an hour on hold to try to get the peer-to-peer. They're faxing letters of medical necessity. No other industry successfully operates in this fragmented, archaic workflow. This is something that once the denial hits, we should be able to ping pong back a documented summary proving them wrong. And there should be accountability because, let's face it, our patients are deteriorating. There's significant risks to patients who have delays in care. There's disease progression, there's hospitalizations, and there's immense suffering. I have patients who go without pain medication, without anti-nausea medication. It's cruel and inhumane that their prescriptions for basic level of care when they're undergoing treatment are not being fulfilled.
And I think asking for pre-authorization for an experimental therapy or off the, non-standard of
Mm-hmm.
care or something you're doing that may not be really, off-label.
Mm-hmm.
I agree with that. I think, you have to
Sure.
justify. But the problem we're facing is that we are asked to do pre-authorization for standard of care. sometimes
Correct.
doing a PET scan for staging somebody where you know it's on guidelines.
Mhm.
That is the issue that is frustrating physicians and nurses and everybody in healthcare. It's why do I need your permission for standard of care testing?
Mm-hmm. Mm-hmm. It's interesting that you say that because the PET scan, that's getting denied.
Of
That's a
course.
very frequent one. So my dream is to have a Waze for healthcare. And if you're a Waze user, you have the report of, a broken down car in the shoulder, right? Or the police up 3/10 of a mile. What I try to do is help patients understand where that roadblock is going to happen. So if I know that at the 3-month mark, we need a PET scan, we're going to start preparing now that they're going to deny that. And what information do you need? Talk to your doctor. They've denied this before, and we have a plan in place so that when that prescription is written and ordered, we immediately already jump on it to say, there's no ifs, ands, and buts about it. This is what the NCC guidelines say. Here's my most recent office note. Here's my physician's note. And if there's any problem, we're going to work up the food chain and contact the CEO. And then we have pushback also with peer health support groups that will help rally on different social media platforms
I
to
was going to
raise and
ask you,
elevate.
Grace. Yeah, I was going to ask you, have you utilized like social media and things like that to kind of shame these people?
Oh, and I have no problem shaming. And I think I'd like to use the lens of raising awareness. And it is a proven fact. I could write a thesis on this. If you tag an organization's social media company, their social media manager will more quickly reply than customer service or the person reviewing your claim. So that has been proven. I would be happy to write that up and publish it if I had time, if I wasn't wasting so much time trying to appeal actual
Yeah.
denials.
Yeah. I want to go through other things that have happened in healthcare. We talked about pre-authorization and insurance, and I loved, before we went on the record, you mentioning about how you really like us to change from navigating healthcare to navigating barriers to
Mm-hmm.
healthcare, which is really the proper terminology, in my opinion. I
Mm-hmm.
totally agree. So let's go through some of the things that just like, you hear about a lot. AI, I mean, you mentioned AI, use chat GPT and things like that. How do there's a lot of AI right now, and I think it's confusing patients. Frankly, it's confusing the non-patients as well. So how do you, as a patient advocate, how do you take AI in healthcare and make sure they're patient-centric?
Mm-hmm. I'm using the tools to help us work faster and smarter. I'm talking very basic, low hanging fruit. I know that there's a lot of potential, but if you think about the average person who may be living with a cancer diagnosis or their care partner or family member, they don't know how to write a letter of appeal. They don't know how to write a letter of medical necessity. They don't know how to craft something convincing. They don't know what evidence they may need. So, even just starting and teaching people how to responsibly and strategically prompt, that is something that I really love to do because by understanding how to ask the right question, you get the output that you need and then you can refine from there. And I'm not aiming for a perfect letter. I'm aiming, let's get something that's pretty solid and strong and representative of your case, and now pass it on to the nurse navigator and say, hey, here's what we started. Can you tweak this? So many people that I reach out to are so thrilled that this is done and given to them with a bow, with the medical records that they need, and maybe some of the information from their insurance carrier. That then it becomes a simpler job. So maybe something that would have taken 3 to 6 hours, maybe it'll take 30 minutes. Is it a
Yeah.
perfect solution? No, but it's helping us work together as a team. And I'll tell you also that the care partner of the person who's living with cancer or whatever the diagnosis is would be willing to catch a grenade for their loved one, and they want to do something. So when there's a denial and they're able to roll their sleeves up and help, it's just very fulfilling and healing and gives people hope. And now it makes them hungry to do more. So once you light that spark in an individual that they're capable of making a difference in their care or their loved one's care, now you have somebody that has a stick of dynamite and is willing to run to do anything, and they want to learn more, and then they're sharing that with their community and others. So there's definitely a network effect. So I think we just need to start teaching. I think a great place to start is how do we use some of these open access uh, chat GPT or whatever LLM tools and teach people how to start prompting, how to start benefiting from them because the access is there available.
Do you accompany patients to their doctor visits?
Yes, I
Have you
do.
done? Okay.
Yes, all the time.
Oh, yeah, that's excellent because you're like an extra set of ears that is listening and providing questions. You mentioned you alluded a little bit to precision oncology. I'd like you to talk a little bit about this. How do there's more advances in precision oncology. There are some folks who are skeptical about precision oncology. Others obviously believe this is the present and the future. As a patient advocate, how do you help patients in the quote unquote era of precision oncology?
When a patient comes to me and they've been either newly diagnosed or they're struggling with their treatment because treatment's not working, they're facing progression, I immediately start looking at the case through the lens of clinical trials. In order to search for clinical trials, I need to have an understanding of the tumor makeup. So biomarkers and genetics clearly play a role, and that's often missing from the patient's case. So it's very frustrating that patients haven't been offered even something simple for immunotherapy. Has PD-L1 staining been done? Has a HER2 marker been tested for? These run-of-the-mill things where to me it becomes very quickly apparent from reading a pathology report or from looking through the most recent medical records that these things are missing. I can't tell you how many times patients have been receiving treatment for months, for years, and we see, hey, has some of this simple staining or some of this simple testing been done? It hasn't been done, and an actionable marker comes up. And the anger and frustration from the families, going back to your other question, are people not doing their job? There's clearly something that's missing that we're not checking off that box to make sure that people are getting these tests that are readily available done. A lot of times I've gotten into interesting conversations with my colleagues in medicine. They say, well, these are so expensive and, I don't think my patient can afford them. And I just want to point out that that's a very dangerous assumption. I understand a lot of these tests are expensive. Some of these could be $5,000 for some of these marker testings and panels. But who are we to say where a person is going to invest their resources? People run GoFundMe's. People may want to allocate and make changes in their financial plan. There may be ways to sign up for a clinical trial that offers this testing. So we're just not even disseminating the availability of these tests to patients, and they can't even be informed that that's available to them. Another downfall and missed opportunity is there's some amazing conferences. I'm thinking back to ASCO. That exhibit hall floor is filled with so many wonderful tools, tests, and technologies and drugs and trials. It's not an open door policy where any patient can really walk in there and peruse and look to see what's available. So it's another silo that we've created. Here's all this innovation, but you really have to be invited to the conference. You have to afford to be able to attend the conference. ASCO does do a good job of having patient advocates there, but it's not really readily available to the public. And I think that these exhibit hall floors at conferences would be such an eye-opening experience to people living with cancer or whatever disease state we would be talking about, because I think it would intrigue people to think differently about their care and what their expectations of their care should be, and maybe where they want to receive their care, because there's so much more out there than people are aware of.
Well stated. Two other topics that are of interest, and you alluded to a little bit earlier in the introduction. One is survivorship. Take me through whether this is a part of your work dealing with people who no longer undergoing active treatment. So they are either in remission or cured or wherever they are. And what do you do with these folks? And then there's another topic.
So I absolutely do have families, and most of the families that I work with are long-term engagements, or in these cases, no evidence of disease, and gratitude that these scans keep coming back clean. That's not to say they're not struggling with a lot of anxiety, scanxiety when those scans are coming up. That's not to say they're not suffering with a lot of long-term consequences and treatment-related side effects that now require follow-up at different places. Neuropathy in the hands and feet that has limited what they're able to do at this time. Younger patients who are dealing with infertility and grieving the loss of being able to have children and a family. It's really hard when we talk about survivorship. And I think one of the hardest things is patients feel that they have this intimate relationship with their oncologist and health system, that they're going there all the time. Then that last treatment stops. And the story is always framed very, very similarly when I work with these patients. Now, all of a sudden, like nobody's watching me. Everyone's forgotten about me. And every time that there's an ache or there's a symptom or there's a change, maybe they're wearing their Aura ring and they notice some differences, or they're using a different tracking app for something, they say, gosh, is this the beginning of a recurrence? Is something going on? So I think that constant living in fear, we don't do enough to support the long-term consequences of treatment. We don't do enough to wrap people in mental health support. We don't do enough maybe for continuous palliative care support with that patient. And I think also, again, connecting to peer health support. And I think lines of communication too with the oncologist. Many patients have a lot of interesting positive and negative feedback from their experience that they want to share. And they don't know where to go with it. They don't want to insult their doctor or hurt their feelings or the care team because they're grateful that there's no evidence of disease. So I think connecting people now, maybe it's the Office of Patient Experience. Is it the Patient Family Advisory Council? There's a lot of opportunities where we close the door and only see a patient in 3, 6, or 9 months or annually, where that patient has so much wisdom and knowledge to give. And we haven't really created a strong conduit to support that.
Yeah, totally true. Grace, another topic is end of life care, and it's obviously it's painful. How involved are you, in that scenario, in telling a patient that there are no other choices and we have to really to focus on hospice care?
Too many cases in my experience. I am very intimately involved in end of life care, and I'm often the trigger for saying we have to have this conversation. A lot of times patients are bounced around between their cancer center of excellence and their local community hospital. And I find that very challenging because the hospitalizations become more frequent. The local community cancer center will say, well, they're not primarily our patient. Nobody wants to devastate the patient. A patient may not be able to travel to the cancer center of excellence. That oncologist and care team no longer have a very close pulse. And the family is told, well, you should really, consider hospice and comfort care. And no one teaches you how to tell someone they're dying. No one teaches us about how to care for someone who's dying. And we really do a terrible job of innovating and supporting people at end of life. It's that last phase of being a patient and a human being that is so ripe for innovating, disrupting, implementation of digital health, actionable insights to care, so that people can, on a daily basis, make really tough decisions about their care, their loved ones' care, when they're no longer capable of making those decisions. We leave people just floundering, and I see it all the time, and it's excruciatingly painful to watch because there's so much unnecessary suffering. Even something as simple as having an advance directive and making sure that everyone understands those needs. We don't have enough support with hospice. People think that when they sign up for hospice, it's going to be 24-hour care. There's a big misunderstanding where maybe it's once or twice a week, where for a half hour, a hospice nurse will come. There's a phone line that's available 24 hours a day, but that on-site care where people say, I want to die at home, people don't really have an understanding of what it means to die at home, when that death can be a slow process over weeks, months, and the final days are really hard. And I can speak from my own experience. My mother-in-law just passed away about 3 months ago, and I was intimately involved in that. And even though this is the work that I live and breathe in, it was extremely hard.
My condolences. I'm sorry, and I can totally relate to to the difficulty of the process and the engagement. How do you handle a lot of the information that comes through to patients when it comes to non-conventional complementary medicine? Um, um, Not to say, I mean, obviously there's a lot of role appropriately to certain things, but there's so much out there. You know, whether it's supplements that maybe we don't know they interact well or good with chemotherapy or radiation, whether it is, you know, interventions from, you know, the acupuncture to cupping to whatever it is. Yeah. Are these things that patients seek your opinion about, and how do you navigate that?
All the time. This is standard practice, and I'm fortunate to work with many immigrant populations and very culturally diverse people from all different backgrounds. And I'm constantly learning about what culturally in someone's country or community where they grew up in thousands of miles away would be standard of practice. And I want to be mindful and respectful of that. And how do I handle that? I'm not a practicing physician, so I can't comment one way or another. But what I try to do is make sure, often what's happening is people feel that they're not getting the care that they need. That treatment's not working, or it's making me so sick. What else can I wrap myself or my loved one with? And they try to bring all of these practices under one roof. I would say from a traditional US oncology standpoint, we don't do enough to manage quality of life, and we don't take these questions seriously enough. Where if I see it all the time, a patient says, well, you know, can I try acupuncture for, you know, my neuropathy? And yeah, whatever. You just go try it. We need to be pointing and connecting people. I find it hard to believe that we don't have references and recommendations or something to connect a patient to. I tell patients if they're trying supplements or if they're doing anything complementary or outside of the conventional, that it should be written down and communicated with the doctor. It has to be in that central source of truth where it's documented in the medical records so that whatever is transpiring, both the doctor and patient are aware. And if there's changes in care or if there's an emergency hospitalization, that it's documented. And I want to also make sure that the patient's care partner is aware if for some reason, really when there's a hospitalization, because that's where it gets tricky very quickly when all of this really isn't documented and the care team has no idea.
I guess my last question, Grace, is pertaining to what happens or how do you handle a situation when you disagree with the healthcare team? They may be giving some recommendations and you just don't think this is the right recommendation for that particular patient, whether it is from a value perspective, whether it is you know, this is might actually affect the patient adversely quality of life because you got to know this patient. I mean, you know, it's hard to imagine that it's always nice and dandy between both sides. We've all been in that scenario where there may not be always alignment. How do you handle this? Must be a tough conversation, whether it is with the healthcare team or with the patient. What do you do?
I handle it calmly and factually, and I think I fall back on my graduate training. I handle it very matter of factly. When I disagree, I go and do my research. I'll rely on whatever standards of care are available, references, peer-reviewed literature, NCCN guidelines. I will find the publications to support my case. I handle it like a thesis and make sure I justify with the references and try to come to a very business strategy. It's not a personal you know, emotional discussion. It's a matter of fact. And then, you know, I think some of the most challenging ones are when there's a recommendation for a very invasive procedure. I had a patient where they were in advanced cancer and a craniotomy and removal of a brain tumor when there were multiple tumors there. The care team felt strongly about that, even though it would not do anything with respect to outcomes, survival, or quality of life. It's definitely challenging, but it has to be handled calmly, matter of factly, presenting all of the facts and making sure that the family understands. What families and patients need to understand, which can be lost, is I need to make sure that they understand how is this going to impact survival? How is this going to impact their quality of life? And what is going to be the progress from here? What is the recovery going to look like? And what are their expectations of quality of life? And what are they hoping to do? Many times people will say yes because they think that it will bring a cure. And oftentimes that's not the case. So as long as the patient transparently understands what this yes decision to saying yes to a treatment means, then I've done my job the best that I can. It's when there's uncertainty, that's when I feel I need to dig deeper. And it often, when I question, I often am met with more conversations which actually help the patient receive more information, and the care team can see where the gray or lack of clarity is and further explain that. And we often are able to come to a mutually agreeable decision. So I think the questioning actually fosters more conversation. I've yet to come to a place where someone didn't want to work with the patient to make the right decision for them.
Anything I should have asked you? I mean, we can talk about this for hours. I am, I think you're doing amazing work to help patients and families in an environment that is very difficult. Unfortunately, I believe you're going to keep doing this forever. I don't think you're going to be out of a job, because I don't think the healthcare system is going to be fixed. Hopefully, it will be improved. But anything that I should have asked you about, anything that you're doing, or you should be like, whatever, just open-ended. I want to make sure everybody is not only aware of what you're doing, but also hopefully be optimistic about the future, that we're heading the right direction, I hope.
I will comment that I do feel that we are heading in the right direction in regards to medical records and access to health information. I think the Office of the National Coordinator has done a fantastic job under the leadership of Dr. Mickey Tripathi in fostering more of a ecosystem that supports information sharing. Having access to the information and medical records that patients and families need is going to make a tremendous difference in people's care. Teaching them how to use that information, it's not just about seeing it, which I call access for access sake. It's access for action's sake. Now taking the information that's there and making it actionable. I'm hopeful that we will start building more tools now once patients can understand their information, or to help patients understand their information. I'm hopeful that there will be more of a prominent role of patient navigators and patient advocates to make them more accessible to the general public, because I know that it makes a difference to have someone by your side, outside and inside point of care. And I'm hopeful that we're going to be moving from doctor knows best, and we went to patient knows best, to now person powered with AI knows best, which means if the doctor is powered by AI and supported, and a patient can be, and their family can be supported by AI and tools, I think that's where the magic is going to happen. And we're going to start tipping the scales on reducing that administrative burden and more quickly connecting people to the care that they need.
Well, Dr. Grace Cordovano, it's really a pleasure to have you on Healthcare Unfiltered. I appreciate everything you're doing. I hope folks check out the services that you have with enlighteningsresults.com, I believe. I've checked out your website. It's very easy to navigate, and there's a lot of information that is valuable for folks. I've also seen you speak and advocate for patients. So I appreciate everything you're doing, and I look forward to having you again on the podcast.
Thank you so much for having me. This was wonderful.